Okay, so I'm going to talk to you guys about cryptogenic stroke, but I'm really going to focus on two parts of that population, PFOs and long-term. We're going to talk about long-term monitoring for AFib in these patients. It's important that you know that I do have a disclosure with Medtronic. I do speak for them sometimes and receive honoraria. The reason why that's important is because I will talk about long-term monitoring today, and they make one of the monitors that is used for long-term monitoring. So first we'll touch on stroke epidemiology, then we'll talk about what it means to call a stroke cryptogenic. We'll talk about PFOs, because I don't think you can have a talk about cryptogenic stroke without talking about PFOs. Then we'll transition into long-term monitoring, and then I'll just close with one of my case examples. So stroke occurs every 40 seconds in the United States, and every 4 minutes somebody dies. We're a lot better at keeping people alive than when I first started training. When I first started residency, we were the 3rd leading cause of death, and now we're the 5th leading cause of death. But it's still the #1 cause of disability. So we keep people alive, but their lives are still very altered. We see about 800,000 strokes per year, and there's 7 million stroke survivors in the US, but it's extraordinarily expensive. So in 2015, it was calculated at a direct and indirect cost of $95 billion, and I looked up those numbers again recently, and it's still very similar, if not higher. In the world, it approximately accounts for 10% of all deaths. More than 15 million people worldwide suffer a stroke every year, and 1 in 3 of those patients will die. Globally, it's the 2nd leading cause of death, and 1 in 3 patients will be permanently disabled. The disability from stroke varies in regards to why people are disabled. What symptoms do they have? So it can be anywhere from hemiparesis to cognitive deficits to depression. And I really want you to look at this graph and see that some of the things that are not as obvious when you meet a stroke patient, the cognitive deficits, the depressive symptoms, and aphasia, a lot of those symptoms happen with cortical strokes. And I'm going to focus a lot today on a subset of cryptogenic, which is an embolic stroke of undetermined source. A lot of our patients will have these symptoms, and which is why they're so disabled. There is a high risk of recurrent stroke that leads to this disability as well, which is why it's so important to figure out why someone had a stroke so we can prevent it. This one study done in 2002 found that over 4 years, the risk of recurrent stroke is 18%. If you look in the literature, this number is actually really hard to define because you're looking sometimes at all cause versus certain different subtypes of stroke, but the risk is high of recurrent stroke in untreated patients. Today we're going to focus on ischemic strokes, although we know there are different stroke subtypes. We're going to focus here on ischemic strokes primarily, which accounts for 85% of the strokes that we're going to see. And if you look at the different causes of stroke, they can be broken down by many different classification criteria. This is the TOAST criteria. So it can be broken down into atherothrombotic, a stroke that's caused from the arteries in the large arteries in the neck or in the head that becomes stenosed 25 to 30% of the time. Cardioembolic 20% of the time, where a clot dislodges in the heart or the aortic arch, travels to the brain and blocks an artery. Lacuna or small vessel, which Dr. Leiden was talking about, 15 to 20% of the time. Uncommon causes like dissection or vasculitis, about 5 to 10% of the time. And cryptogenic, which is actually defined as unknown, or if you have 2 plausible causes, I think we forget that sometimes, is that either one of those can be defined as cryptogenic. And that's not a small part of this population. It's 25 to 30% of the strokes that we see. If we assume that there are 700,000 ischemic strokes per year, about 200,000 of them are cryptogenic. So again, there's that 30%. But the term cryptogenic is not well defined. If you ever look in the literature, it's been used for so long, but it's so incredibly varied as to what is defined as cryptogenic stroke. And if you go to one neurologist versus another neurologist, you might have a completely different workup. One might be very extensive, and one might be, not as extensive. So the TOAST criteria actually doesn't specify what the required workup is. They use the term cryptogenic and say if you don't find the cause, it's cryptogenic, but they don't say what that means. What did you have to do to get there? The CCS classification scheme requires brain imaging, a 12-lead EKG, and 2D echocardiogram, and vessel imaging of the head and neck. ESIS, which I think is the definition we should all be transitioning to, defines all of those criteria that are necessary, but in addition requires at least 24 hours of cardiac monitoring. How many of you have heard the term ESIS? Okay, so it's not very widely used is what I realize every time I give this talk. I've realized that people actually aren't using it, and they're still using the term cryptogenic. And I kind of hope that you leave today and realize that this is a better definition for many of these strokes that we're going to talk about. The ASCO phenotyping does not include a cryptogenic stroke category. So what does ESIS mean? ESIS basically means that it's a non-lacunar brain infarct without stenosis of the proximal arteries, no cardioembolic source, and it's really implying that you've done a full standard evaluation, whereas cryptogenic didn't really require this full evaluation. So what do you need to say that you're ESIS? So you have to find a stroke on CT or MRI. It can't be lacunar, but it can be a lagoon, right? You guys heard that term where it's kind of a larger subcortical stroke. So if it is greater than 1.5 on CT or greater than 2 on MRI, DWI, that's still a stroke that you can consider an embolic stroke of undetermined source. Once you've ruled out stenosis in the arteries of the neck or head, it cannot be more than 50%. No major risk for cardioembolism, so they can't have an EF of less than 30% or an MI within 4 weeks. No AFib, obviously. No other identified cause of stroke. And what this is really looking at, again, is this subset of cryptogenic stroke that we think a clot has traveled from elsewhere, most likely the heart. And it's basically saying we need to look closer, okay? So this is just a basic workup. This was actually in the neurology clinical practice. I found it very helpful into what the suggested approach is for cryptogenic stroke. So you've done your basic workup and you've gotten your history. You identified the mechanism and the patient has risk factors. You can probably stop there. What about if they have no risk factors, but on imaging it looks lacunar? Well, you can then say, well, they have risk factors and stop. If they have no risk factors, then they do, if you have a lacunar infarct with no risk factors, then you're probably going to be cryptogenic. If you have no stroke mechanism defined, then you're also going to be cryptogenic, which could lead to a very extensive workup. You might do further cardiac workup, including a transesophageal echocardiogram. You might do further aortic arch imaging. You probably are going to do more prolonged cardiac monitoring, which we'll talk about, to rule out AFib. Sometimes you'll do vessel wall imaging to see if it's something obvious in the vessel wall. Maybe you find a dissection. Maybe you find evidence of vasculitis. And then sometimes we'll even do lumbar punctures in these patients to look for more rare causes. But I don't think we can talk about cryptogenic stroke without talking about PFOs, especially in light of the more recent trials that have come out. So let's talk about that. A PFO is a connection between the left and the right atrium at the fossa ovale, which remains open after the fetal circulation. It occurs in about 20 to 25% of the population, and it's implicated in the etiology of cryptogenic stroke. But we know that 40% of adults with cryptogenic stroke have these. It doesn't mean that it's necessarily what's caused their infarct. A large percent, 20 to 25% of us in this room have a PFO. It doesn't mean that we're going to have a cryptogenic stroke. We know that the prevalence is greater in those that are less than 30 years of age and lower in those that are 80 years of age. Up until 2012, there had been tons of observational studies and there had been clinical opinions about what should be done with PFOs, and we were closing them kind of left and right. I don't know if you guys remember this, but we were closing them, and then all of a sudden it stopped because insurance companies stopped covering it. And the reason why is that because multiple trials were done. 2012, we had closure. 2013, we had the PC trial. And then we had the closed trial in 2017. All of these studies on this slide compared the closure device to either an antiplatelet plus minus an anticoagulant, okay? And when these three first studies came up negative and didn't show any statistical significance for PFO closure, they were pretty much stopped. Cardiology stopped doing them. They weren't being reimbursed, and it really wasn't done outside of clinical trials. Luckily, it was studied further, and the RESPECT trial was done, which looked at the Amplatzer device compared to any antiplatelet therapy or anticoagulants, and they found that there was a significantly lower rate of ischemic stroke in the PFO closure arm, but there was a higher risk of venous thromboembolism in that arm, which we'll talk about why. What we think the reason is because the other arm had anticoagulation on board, so that actually probably skewed that. The Gore reduced study also looked at the septal occluder device, and it looked at strokes that had a moderate, large to large size shunt, and that also was showing significant lower clinical ischemic stroke in the PFO closure side, but there was a higher risk of atrial fibrillation. So after these studies were done, if you look at them, you can see that they did have limitations. So none of the trials required prolonged cardiac monitoring. If you look at any trial that's looking at a cardioembolic stroke, that should be a requirement, right? It seems like that would be common, right, to do that. But it actually wasn't at that time. And so they didn't require to rule out AFib essentially as a possible etiology in these patients. And they also didn't select out well enough. They used the term cryptogenic, so it could be as defined, using the cryptogenic terminology, but not ESIS. ESIS would have been a richer population and probably the more appropriate population to look at. Also, if you look at the primary outcomes, they included recurrent stroke of all cause and not just cryptogenic. So what did we learn from them? Well, if you look at the RESPECT trial, if you remember, that trial was originally negative. When the results were first released, it didn't show us that there was a benefit for PFO closure. But when they did longer term follow-up, that's where that was demonstrated. And it really showed us that in these low event rate disease processes, you really have to follow the patients out further to be able to see what's going to happen with them. It also showed us that an atrial septal aneurysm in a large shunt would predict a greater treatment effect than people that had a smaller PFO or no atrial septal aneurysm. The greater treatment effect for PFO was also suggested when compared with antiplatelet therapy, but they didn't see that in the anticoagulation arm, so it didn't really help us in regards to decisions about using an anticoagulant. There were more DVTs, but we think that's because the medical arm had about 20% of patients that were on anticoagulation. REDUCE was also successful. It showed us that the number needed to treat at only 2 years was approximately 28. But again, there was atrial fibrillation in the PFO closure arm. In CLOSE, also very positive. These patients had large atrial septal aneurysms and shunts. It reduced the recurrent stroke risk in this group. But again, AFib was more common in the PFO closure arm. So then what happened? We had all these new data, and now we need the guidelines, right? But none of the guidelines have caught up yet, which is kind of puts us in this quandary, right? Because we have the data, but we don't necessarily have anyone helping us with the guidelines. So if you look at all the guidelines, they still to this date, 2014 the American Heart Association and the 2016 AAN still say that PFO closure should not be done outside of a research trial, and that it could be considered in someone that maybe has a DVTs. So then it leaves us again in this weird position. So there are algorithms, though, that are very helpful to help you decide maybe what patients should go on to PFO closure. So all of the studies had patients that were 61 years of age or lower. And so if you have a patient who's less than 60 with a stroke and a PFO, let's look at their risk factors first. If they have all these risk factors, well, it's more likely that one of those major risk factors caused their stroke, and you should probably treat them with medical therapy. But as you go down the list and you don't find any of those risk factors, no high blood pressure, you do a 30-day cardiac monitor, you don't find any AFib, then you really should be considering PFO closure, especially if they have any of the enhanced reasons like prior DVTs, multifocal cerebral infarcts, a large PFO, or an atrial septal aneurysm. So you really need to look at each patient very independently. Have any of you used the ROPE score or heard of the ROPE score? Okay, so the ROPE score is a score that looks at PFO patients and helps to tell you if the PFO was the attributable cause for the stroke, essentially. What was the likelihood that it caused it? And so the score is between 0 and 10. 10 basically tells you that this is most likely the cause of their stroke. And what you can see is that those people are typically younger, they don't have risk factors, and the stroke is typically cortical. And what they found is that as you go higher, the ROPE score is higher, but the risk of having a recurrent stroke is actually lower because these patients don't have a high risk of recurrent stroke. So this paper, I think, is the most helpful paper I have found. I recommend everybody read it. If you see patients that have PFOs in your clinic and you're not necessarily sure what to do or how to have a discussion about it, it's extensive, but it's so helpful. So the citation's on the bottom there if you want it. So basically what this study showed, and it's a bunch of cardiac and neurology experts in Europe that put this paper together, is that we know that the risk of recurrence in these patients is low based on the prior studies that have been done. Recurrent stroke risk on medical therapy is about 4.6 over 3.8 years of follow-up. But when you look at PFO closure, the number needed to treat to prevent one stroke of all patients is 37, and of patients with high-risk PFOs, meaning large PFOs with spontaneous shunting and atrial septal aneurysm, the number needed to treat was only 21. Again, an atrial septal aneurysm, a moderate to severe shunt, and atrial septal hypermobility are all strongly associated with a causal role of PFO. An atrial septal aneurysm also conveys a higher risk of recurrence. The rope score is helpful, but it should never be used by itself. It's just a tool to help make this kind of complicated decision. The other thing that they recommend, which I think in my practice has been very helpful, is that it really should be an interdisciplinary conversation between you, the patient, and a cardiologist. If you're lucky enough to have a cardiologist that's an expert in PFOs but doesn't close them, I find that to be the most helpful. I have one such at my program, and I send many of my patients to have just a discussion about the PFO and what they think are the highest risks about it, because they're essentially very unbiased. So this is from the paper. It's a workup that's recommended in these patients where they have a PFO and you're not sure if the stroke was due to it. So you basically do your first-line diagnostic workup, especially to rule out arrhythmias, at least 24 hours of monitoring. Obviously, to detect AFib, you're going to stop your workup and treat them. They don't have AFib, but you feel confident that the PFO caused the stroke, maybe based on the rope score and all the clinical information you have, then you're also going to stop and close your PFO. But what if you're not sure? You've done your workup and this happens, I would say, probably in most of our patients. You're really not sure if it's related. Well, if they're less than 55 years old, then you're going to look for some of these risk factors below. If they have none of those risk factors, then you can stop and consider closure in that patient. If they have those risk factors, though, you should really be considering more of a workup and more prolonged monitoring, right? So ICM is just prolonged cardiac monitoring. And you have to decide what that is, how long that is for you. I've typically been using at least 6 months in my patients, and then I revisit the PFO if I don't have AFib. If they're 55 to 64 and they have risk factors for AFib, then you're probably going to stop your workup. If they do have risk factors for AFib, you're probably going to put the loop recorder in. If they don't have them, you might still consider closure in this population. Remember, up to 61, they were included in those trials. Greater than 65, we really don't know. We're kind of in no man's land. We think that as you get older, it's much less likely the PFO is related to your stroke. Those are patients in which I'm going straight to prolonged monitoring, and we have a discussion about their PFO, especially if it has high risk factors and the patient is very healthy and they don't have risk factors. That might be a patient you might consider doing it kind of outside the box, but in those patients, you really should be considering other causes. These are just some case examples from my clinic. So the first one was a 30-year-old female. She was very healthy, no past medical history. She came in with a left MCA stroke. We did a 2D echo. It showed a PFO on her bubble study. We did a TEE, and it ended up being a large PFO with an atrial septal aneurysm. She had a high-risk PFO. She had a high rope score and no risk factors. She was pretty straightforward. I still do 30 days of monitoring on my patients, though, no matter what. I've been surprised before, so I did a 30-day monitor on her. It was negative, and then she had her PFO closed. The next one was a 55-year-old male. He had multifocal embolic appearing strokes, multiple risk factors. His 2D echo showed a moderate-sized PFO, and the TEE showed the same, didn't show any atrial septal abnormalities. So he's, in the middle group. He has moderate risk PFO and traditional factors. We decided to refer him for the implantable loop recorder, and that if no AFib was found at 6 months, we were going to revisit. I have seen him since. He still doesn't want to close, which I think is appropriate, and he continues to have the loop recorder in. The next one is a 70-year-old female. She has multiple risk factors. She came in with a right PCA stroke and a small, moderate-sized PFO and no high risk factors. And for her, it was pretty straightforward. We referred her for an implantable loop recorder, and I told her it's reasonable for us to discuss it every time we see her every 6 months, but in those patients, I'm much less inclined to consider a PFO closure. The evidence just doesn't support it. So for PFOs, in summary, closure is of moderate benefit compared to antiplatelet therapy alone in preventing recurrent stroke in adults up to 60 years of age. We should really select these patients carefully for those that meet the strict criteria, and the decision-making should be, with a group. It should be a cardiologist, a neurologist, and the patient, and you should still be considering long-term monitoring in those patients. So I want to transition back out now to go back out to cryptogenic stroke. So of the 200,000 cryptogenic stroke patients, most of them are going to receive antiplatelet therapy, and that's kind of by default. Our current guidelines say if you have a cryptogenic stroke, put them on antiplatelets. We've had 2 studies that you all may have heard of or been involved in. We had Navigate ESUS and Respect ESUS that looked at oral anticoagulants, dabigatran and Xarelto, and it didn't find that there was benefit for putting cryptogenic patients on oral anticoagulants. Another study is currently being done by the NIH is Arcadia. We're doing it at UCSD. It's looking at a very specific subset of ESUS patients with cardiopathy, and who knows what that will show. That might show that a specific portion of these patients might benefit from oral anticoagulants. But for now, the majority are on antiplatelets, which is truly problematic because if you do long-term monitoring on these patients, about 30% of your cryptogenic stroke patients actually have AFib, and they should be on an anticoagulant, not just an antiplatelet. So it's our job to look for that. If you look at stroke, for risk of stroke in patients with AFib, we know it's the most common cause of embolic stroke, and 15% of strokes in the United States can be attributed to atrial fibrillation. AFib is also associated with an increased mortality from 1.3 to 2 times. You're at a 5-fold increase for ischemic stroke if you have atrial fibrillation. You're 2 times more likely for an AFib-related stroke to be fatal versus a non-AFib stroke. And that's because those clots are large. They get lodged in large arteries and cause massive strokes. There's a 67% decrease, however, in stroke risk with oral anticoagulants. So we find AFib, we can help these patients out. So how do we find it? There's tons of different cardiac monitors you can do, right? So you have your telemetry in the hospital, we have Holters, we have mobile cardiac telemetry, and then we have patches and implantable loop recorders. So let's talk about each of these. So Holter monitors, I don't order them ever because I think they're a waste of energy for the patient and the yield is low. So they're 24 to 48 hours of monitoring. It's an external loop recorder and it saves all the data. But again, you're only getting it for a day or two and the patient has to come in, have it placed. And these are often, your patients in your 70s. Some of them don't have a car. They got to come in, get it placed, go home, come back, drop it off. The VA is the only place I order them because they make me, but I don't ever order the Holters. Event recorders, though, up to 30 days of monitoring, they're event triggered, and it saves the events that occur only. And it's really only up to 62% patient compliance. What you're going to see in a little bit, and you're probably already aware from your practice, is how can they know when to press it? A lot of them don't even know when they're in AFib, right? A lot of times we see them in the hospital with their first stroke, and that's the first time they figured out they had AFib. MCOTs I do use. So these are up to 30 days of monitoring. It's an ambulatory event recorder. It saves all of the rhythm data, but the patient compliance is varied. So you have to really decide, is your patient someone that's going to be able to wear this patch and make sure that they're switching out the battery and those types of things, okay? And then we have implantable cardiac monitors or insertable cardiac monitors, also called loop recorders. And there's been a ton of studies that have looked at these as well. The most recent and I think relevant study is Crystal AF. So all of these studies look at days to detection and yield of detection. So the days of detection varies, anywhere from 48 to 161, with Crystal AF being 84. And the yield is also variable, anywhere between 16 to 33%, with 30% being detected in Crystal AF. Let's talk about the Crystal AF. It's a randomized control trial with 441 patients. It was published in the New England Journal of Medicine in 2014. It compared continuous long-term cardiac monitoring. They used the Reveal implantable loop recorder. This is why my disclosure is important, because that's made by Medtronic. And so it used that versus conventional monitoring for AFib and cryptogenic stroke patients. They assessed them routinely, 1 month, 6 months, 12 months, and as needed. And then the control arm, the EKG monitoring arm, was basically at the discretion of the investigator. So it was comparing it to what the real world was doing, essentially. The endpoints were primary, time to first detection of AFib greater than 30 seconds at 6 months of follow-up, and secondary, time to first detection of AFib at 12 months, recurrent stroke or TIA, or a change to an oral anticoagulant drug. There were 447 that were enrolled and 441 that underwent randomization. There was some crossover, which was minimal, and it ended up with 221 versus 220 patients. The patients that were enrolled, so they had to be greater than or equal to 40 years of age. They had to have a diagnosis of stroke or TIA within the past 3 months. And they actually had pretty extensive testing. And aside from having the basic workup and 24-hour monitoring, it's one of the first studies I've seen where they required a TEE on every patient before they called it cryptogenic. If they were less than 55, they also had a workup for hypercoagulable states, and they had imaging always of the head and neck vessels. If they couldn't get it because of some type of reaction or there was a reason why they couldn't, they were able to do transcranial Doppler and duplex as well. So they were really only categorized as cryptogenic, or in my opinion, majority of them were ESUS, after extensive testing being done. The patients were well matched. Majority were male and white, and the majority of patients were stroke and not TIA. It's important to note here that the PFO was similar to the population. So the PFO incidence was between 20 and 23%. What they found was that monitoring with an implantable loop recorder was superior to standard of care detection for AFib. If you look on the x-axis, it's up to 3 years, and the y-axis is AFib detection. And what they found over 3 years was that the control arm only found AFib 3% of the time, whereas the implantable loop recorder found AFib 30% of the time. If you look at median time to randomization to detection of AFib, it was 41 days versus 32 in the control. But they found 19 patients in 6 months with AFib in the implantable arm versus 3. And if this number is so important, 74% was asymptomatic, which is why an event monitor isn't going to help you. These patients don't know they're in atrial fibrillation. So 74% and 33%, and it changed the anticoagulant use 94.7% of the time. If you look at what was required to detect AFib, though, in the implantable arm, it was the loop recorder, but in the control arm, they had 88 EKGs, 20 24-hour Holters, and 1 event recorder. That's relatively cumbersome for your patient, and it is expensive. When you look at the 12-month endpoint, median time to detection of AFib was 84 versus 52. They found that 79% of patients that were in AFib were asymptomatic. And it changed their oral anticoagulation to majority of the time, 96.6%. And again, instead of a loop recorder, the other arm did 121 EKGs, 32 24-hour Holters, and 1 event recorder to find AFib in 4 patients. There were complications. At the beginning of this trial, they were using a submuscular, I don't know if you guys remember it, it was a submuscular implantable loop recorder. It was a lot bigger. It was kind of the size of a pen drive. And that 2.4% of the time there was an infection or pocket erosion. We no longer are using that one though. So I think both companies that make the majority of the devices, they're smaller now. And so they don't typically have that problem. The secondary endpoint at 12 months, 97% of patients in whom AFib was detected received oral anticoagulants, and the days to detection again was 84 versus 53. So then what happened after Crystal AF? Well, then there's been a couple studies that have been done. This is some data from a real-world validation by Dr. Rogers. He presented it in 2016. Again, this is not a randomized trial. This is just his own experience with patients. So he had done at this time 1,247 implantable loop recorders. The cryptogenic stroke diagnosis was not the same as a trial. It was based on the physician's discretion, and they did a follow-up of 12 months. The diagnostic yield in his community was 16.3% at 12 months, and the median time to detection was 86. So it really supported the data of that randomized control trial and basically tells us that it is warranted to continue to monitor these patients. It will lead to changes in treatment. Some other sub-analyses that have been done. So this one was looking at the predictors of AFib and letting us know, are we able to predict who of our patients are actually AFib patients by looking at their age, their BMI, their CHA2DS2-VASc, their diabetes, if they have CHF. And what we found was actually that aside from, so increasing age and a prolonged PR interval were independently associated with AFib, but the predictive ability of these parameters was only moderate. So we're really not great at predicting who is going to have atrial fibrillation. There was another sub-analysis that looked at continuous monitoring compared to intermittent using simulated intermittent monitoring in 168 of the patients that were found in Crystal AF to have atrial fibrillation. And the periodic monitoring and short-term monitoring were anywhere from 24-hour to 30-day event monitors, and they monitored them quarterly all the way out to monthly. And what they found was that intermittent rhythm monitoring would have failed to identify previously undiagnosed AFib in those patients. The sensitivity was low and the negative predictive value was high. This is just an illustration to show you why extended monitoring is probably beneficial. So if you look over time, if these blue lines are AFib and the green arrows are every time you do, like a 30-day monitor or a Holter, you are very likely to miss when people are going in and out of AFib. And the reason is because the majority of them don't know they're in AFib. So when are we gonna know, how are we gonna know when to put a monitor on somebody if they don't know when they're in atrial fibrillation? It's really random. Based on the data that we had so far, these are the most current guidelines for monitoring a cryptogenic stroke. So the ESC guidelines for management of AFib told us that in stroke patients, additional EKG monitoring by long-term non-invasive EKG or an implantable loop recorder should be considered to document silent AFib, and this is class 2A level B. And then in 2019, the American Heart Association gave us a focus update for the management of patients with AFib, and they said in patients with cryptogenic stroke in whom external ambulatory monitoring is inconclusive, an implantable loop recorder is reasonable, and that was 2A level B, R. Since those guidelines have come out, there was a meta-analysis that was published in June of 2019 in stroke, and this was to evaluate the impact of prolonged cardiac monitoring on secondary stroke prevention from the current trials that we do have in observational studies. So they looked at 2 randomized control trials and 2 observational studies and did a comprehensive lit search. And they found that in patients who underwent implantable loop recorders versus conventional monitoring, there was a 2.5 increase in the incidence of AFib detection, 2.1 increase incidence of anticoagulation initiation, and a 55% decreased risk of recurrent stroke. They concluded that the use of prolonged cardiac monitoring has a potential impact on secondary stroke prevention, as patients with cryptogenic stroke or TIA undergoing prolonged cardiac monitoring had higher rates of AFib and anticoagulation use and lower risk of recurrent stroke. So how do you do this? Everyone's really varied is what I've recognized. Some hospitals do them all the time. The patients leave the hospital with them. We don't do that at UCSD. I would like to have them implanted before they leave. I think it's easiest for patients in that way, and they've already been on telemetry sometimes for multiple days. So when a patient comes in with a stroke or TIA, it's going to change their management. If you're going to put them on anticoagulation, you really should be considering an implantable loop recorder. So if you're lucky enough to be able to have them as an inpatient, the best thing to do is do your cryptogenic workup, whatever labs you're going to send off, and stick it in before they leave the hospital. Again, we're not doing that. What we do is a bridge. So we always put in mobile cardiac telemetry, a 30-day monitor on when they leave the hospital. They leave with a monitor, and then they follow up. We follow that up, and then we refer them if that's negative. I think what was happening before for us, which was frustrating, is they would leave the hospital, then we'd have to wait to see them in clinic, and then we would we'd send the monitor in the mail, and it was taking, 4 months. They were walking around unmonitored. This way, at least, although they don't get the loop placed immediately, they get the external patch, and then they eventually have that placed. It's really small. Patients, I haven't had any patients complaining about it. They basically go home with, the loop. They go home with a cell and a complete monitoring system that they're able to be monitored with wherever they're living. And I'll just tell you about one of my patients. So this is a 62-year-old male. He presented with aphasia and right-sided hemiparesis. He got TPA. His MRI demonstrated still a pretty decent-sized left MCA stroke. He had an extensive workup. So we had vessel imaging, a transthoracic and transesophageal echocardiogram. I sent a hypercoagulable panel. Usually my cutoff is 60 years of age, but I didn't have a lot of risk factors for him, so I decided to send that on him. He had inpatient telemetry, a 14-day monitor that didn't reveal any causes, so I referred him to cardiology for the loop recorder, and he was put on Plavix in the meantime. Eventually, these are actually his reports, so he was found to be in atrial fibrillation. Pretty immediately, we called him, put him on Eliquis. He lives in an RV, still has the loop in, and he moved to Tucson, and now his EP over there is actually monitoring him. But this definitely changed his management and decreased his risk of recurrent stroke. So in conclusion, stroke continues to be the leading cause of disability, and secondary prevention is key. The only way we're going to be able to prevent stroke, though, is to find out why somebody had it. So you should be taking a closer look of your cryptogenic population. If they're ESUS, then you really should consider a more extensive workup. If they have a PFO, consider the things that we talked about today, and have a multidisciplinary discussion about those patients. Should their PFO be closed? And even if you're going to close it, consider monitoring them for AFib. We know that the longer we monitor, the more likely we are to find AFib, and it will lead to a decrease in their risk of having a stroke if we can put them on anticoagulants. And that's it.